This is a continuation of Chapter 9 in the Patient Care and Radiography. This is Chapter 9, starting on page 152. Even no symptoms are present, therapy may be recommended when a skin test is newly recognized as positive, depending on the individual's risk factor. This therapy usually consists of ionized administration of a period of 6 to 9 months to prevent active disease. If the symptoms are present, a chest radiograph is ordered to rule out active disease. When there is no symptoms or signs of active disease on the chest radiograph, septum smears and cultures are tested for acid-fast maculae. Positive results are definitive proof of active disease and are indications to begin treatment. Screening is often mandatory for those who work in contact with vulnerable or high-risk patients. Those examples include school teachers, corrections officers, healthcare workers, and are often required to have pre-employment TSTs. In 2013, the CDC reported approximately 9,500 new cases of TB diagnosed in the United States. This is the lowest number reported since the case national reporting began in 1953, when over 84,300 new cases were documented. Although TB rates have been declined in both American-born and immigrant populations, the decline has been substantially lower among foreign populations. The continued decline in the number of reported cases since 1992 reflect improvements in the TB prevention and control programs by state and local health departments, but falls short in the national goal the CDC set to eventually eliminate the disease from our population. Although we have seen a decline in the number of new cases in the United States, TB is still a worldwide problem. 1/3 of the world's population is infected with TB, and TB is the infectious disease with the second highest number of cases in the world, with HIV and AIDS number of cases being first. According to the WHO, there are 9 million new cases reported globally in 2013. 1.1 million of these cases occurred in individuals with HIV, and 480,000 cases were identified as multi-drug resistant TB, MRD TB. TB tends to be a disease of poverty, affecting mostly young adults in their reproductive years. The vast majority of deaths are in the developing world. 1.5 million such deaths were attributed to TB in 2013. Since 2002, a number of foreign-born persons with TB in the United States have exceeded the numbers of TB cases in American-born persons. Foreign cases in the United States will continue to increase and outnumber the United States-born cases if global TB control is not achieved. This means that this disease may never be eliminated from the United States, and radiographers will continue to X-ray and care for patients with this disease for a long time. Early identification, isolation, and treatment are required to minimize transmission of TB. Healthcare workers are at a risk of contracting this disease if the patient is exhibiting signs and symptoms of active TB. The diagnosed patient will be isolated in a room with negative pressure. Air flows from the hallway into the room, and more than 6 air exchanges per hour. Personnel and visitors must wear special masks and follow all precautions and procedures designated by the institution for the care of patients with airborne infections. See page 159. According to OSHA standard of TB, the infection control experts within the healthcare facility are to assess the actual risk of TB transmission for in- and outpatient settings. If the findings reveal risk, they are to develop TB infection control interventions. These include free TB skin and blood tests, the provision of personal respirator equipment, and operation of one or more isolation rooms with negative air pressure and special ventilation or circulation, annual employee training about these diseases, and implementation of effective work practices. OSHA estimates that the average lifespan occupied risk of TB infection may be as high as 386 infections per 1,000 workers exposed to TB on the job. The average lifespan of occupational risk is developing active TB disease ranges from 3 to 39 cases per 1,000 exposed workers. Preventing disease transmission. Historical prevention. When infectious disease was rampant, those infected were often quarantined, meaning all members of the household were prevented from leaving the house or allowing others to enter. This practice helped to confine the infection into one family. Although the quarantine is no longer commonly used, the United States Public Health Service still has legal authority to detain and quarantine individuals when necessary to prevent the spread of certain serious infections. Diseases for which quarantine is currently authorized include cholera, diphtheria, infectious TB, plague, smallpox, yellow fever, SARS, viral hemorrhagic fever such as Ebola. Decades ago, hospitals developed policies that involved separating patients admitted with infectious diseases from other patients. Contact with other patients was rigidly controlled. This isolation was a logical outgrowth of the practice of quarantine, and these techniques provided for specialized methods of asepsis when the danger of disease transmission was exceptionally great. Although isolation techniques were effective when used correctly, no mechanism existed for the prevention of serious disease carried by asymptomatic individuals, such as those with HPV or HIV. The following paragraphs describe the systems and precautions that were used before the current system standard precautions. These systems were introduced to protect healthcare workers from contracting infections from all patients, regardless of diagnosis, by preventing contact with their blood and body fluids. Universal Precautions, 1985. In acknowledgement that many patients with bloodborne infections are not recognized, the CDC introduced a system in 1985 known as the Universal Precautions, or UP. Under this system, all patients were treated as potentially reservoirs of infection. The system is based on the use of barriers for all contact with blood and certain body fluids known to carry bloodborne pathogens, rather than focusing on isolation of a patient with a diagnosed bloodborne disease. The needs that use barriers such as gloves and masks depend on the nature of the interaction with the patient rather than the specific diagnosis. Emphasis is placed on blood and certain body fluids as potential sources of infection regardless of diagnosis. Body Substance Precautions, 1987. Because UP placed emphasis on bloodborne infections and did not include precautions for the contamination by feces, nasal secretions, septum, sweat, tears, urine, and vomitus, unless contaminated with visible blood, a new system was introduced in 1987 called Body Substance Precaution, or BSP. This system is focused on the use of barriers for all moist and potentially infectious body substance from all patients. This system was developed to protect healthcare workers from acquiring and transmitting infections from all patients. Standard precaution. In 1996, the CDC recommended a new system that combined the features of UP and BSP. This is the current system and is called the standard precautions. In recent years, some documents refer to standard precautions as universal precautions. To avoid misunderstanding, this text continues to refer to the current system as standard precautions. Standard precautions refer to an infection control system designed to reduce risk of transmission of infection from unrecognized sources of bloodborne disease and from other pathogens in healthcare institutions. Standard precautions are also reduce the risk of transmission from recognized sources of infection by including precautions of three modes of transmission: airborne, droplet, and contact. These transmission-based precautions are discussed later in the chapter in the section on isolation techniques. You must decide when to take the extra time to protect both yourself and your patients. How you assess these risks and respond to these will vary with the setting and your level of experience. As a beginner student, your level of precaution should be very high. Although you may observe more experienced workers taking fewer precautions, do not think you must follow their example. At this stage in your education, it is far better to take too much precaution than too little. OSHA Bloodborne Pathogen Standard. OSHA published the Occupation Exposure for Bloodborne Pathogens Standard in 1991 to protect workers exposed to blood and other potentially infectious materials. As a result of this standard, employers are required to develop an exposure control plan for a work site describing employees' protection measures. The plan must include how employers will use a combination of engineering and work practice controls, ensure the use of personal protective clothing and equipment, provide signs and labels to identify biohazard materials, and take other measures to protect workers. Employers must also provide an annual bloodborne pathogen training, hepatitis B vaccinations, medical care in the event of occupational exposure. Congress passed the Needle Stick Safety and Prevention Act in November of 2000 in response to the high number of skin punctures occurring with contaminated sharps. OSHA continued to revise this bloodborne pathogen standard to expand the definition of engineering controls. The revision defines engineering controls as use of effective and safer medical devices such as sharps with engineered sharps, injury protection, and needleless systems. The revision became effective in 2001. Some of these devices are illustrated and described in Chapter 14. As part of this policy, employers must document the process used for consideration and selection of these safer devices and involve employees in this process. Medical asepsis. Medical asepsis deals with reducing the probability of infectious organisms by being transmitted to a susceptible individual. The healthy human body has the ability to overcome a limit of number of infectious organisms, but the resistance can be overwhelmed by a massive exposure. On the other hand, reduced resistance can be caused by a disease, cancer, chemotherapy, immunosuppressants, or extreme in ages that may result in infection after only minimal exposure. Pure organisms at which the patient is exposed are more likely that he or she will resist infection. The process of reducing the total number of organisms is called microbial dilution and can be accomplished in several levels. At first, simple cleaning measures such as proper cleaning, dusting, linen handling, and hand hygiene techniques can reduce the transmission of microorganisms. The second level is disinfection and involves the destruction of pathogens by using chemical materials. The third is surgical asepsis or sterilization. This involves treating items with heat, gas, or chemicals to make them germ-free. The sterile items are then stored in a manner that prevents contamination. Surgical asepsis and sterilization techniques are discussed in Chapter 18. Armed with the knowledge of disease transmission, how can you help fight the spread of infection? Stay home when you are ill if possible. If you must work, avoid contact with immune-compromised patients. Use a tissue to cover your mouth when you sneeze. Wear a mask if you are coughing. If a tissue or a mask is not available, sneeze or cough into your elbow as do not contaminate your hands. If a tissue or a mask is not available, wear a clean uniform or a hospital scrubs daily and remove them before leaving the hospital or clinic. The best option is to wear hospital scrubs so they can be laundered by the hospital. Perform hand hygiene frequently, especially after touching your face and blowing your nose. Use established precautions when handling patients, linens, and items contaminated by body substance. Changing or removing contaminated gloves after handling a patient or before touching other objects or equipment in the room. Practice good housekeeping techniques in your work area. When in doubt about the cleanliness of an object, do not use it. Dispose immediately of linens, instruments, or other items that touch the floor. The floor is always considered contaminated. Ask patients who are coughing or sneezing to cover their mouth and noses with tissue or masks. Hand hygiene. The first three principles of preceding list are simple and self-explanatory. Hand washing can also seem obvious, but it is frequently overlooked in many hospital settings. Unfortunately, evidence shows that most physicians, nurses, and other healthcare workers do not wash their hands often enough or well enough. There are several reasons that contribute to poor adherence to regular hand washing in healthcare. Healthcare facilities. Inaccessibility to sinks, lack of time in between patients, lack of role models, and concern that hand washing is irritating to the skin, causes dryness. Medical aseptic hand washing is illustrated in Figure 9-1. based on page 156 and 157. As previously stated, the CDC estimates that each year nearly 722,000 patients in the United States get an infection in the hospital, and about 75,000 patients die as a result. In an effort to address this adverse outcome, the CDC issued a revised hand hygiene guideline in 2002. An important part of the guideline is recommended to use an alcohol-based hand rub, a preparation in the form of a gel, rinse, or foam containing 65 to 95% isopropyl or ethanol alcohol. Alcohol-based hand rubs have some benefits that the CDC believes will improve compliance with hand washing hygiene. Use of an alcohol-based hand rub requires about 15 seconds of time versus a minute to walk to a sink, 15 seconds of time, and another 30 to 60 seconds to complete the hand washing procedure. An alcohol-based hand rub is more accessible than a sink because dispensers are located throughout the healthcare facility and are installed with less expense in a smaller place than a sink. Again, see figure 9-2 on page 157. Additionally, hand rubs have been found to be more efficacious than soap and water in reducing the incidence of non-scomal infections. They are no less irritating to the skin, especially when skin conditioning agents are added to the formulation. They are very effective against many microorganisms, gram-negative, gram-positive, M. tuberculosis, fungi, and some viruses, including multi-drug resistant organisms. However, hand rubs cannot destroy bacterial spores such as those of C. diff and Bacillus anthracis. Hand washing with soap and water is still recommended to physically remove spores from the surface of contaminated hands. Alcohol-based hand rubs do not replace hand washing with soap and water with hands are visibly soiled or contaminated with blood or by body secretion or excretions. Gloves should be always worn to prevent contact with the patient's blood and other body fluids. Following the removal of gloves, the hand should be decontaminated through the use of aseptic hand rub or aseptic hand washing to reduce the bacterial count. Studies reveal that healthcare workers who wear artificial nails are more likely than those who have natural nails to harbor bacteria on the fingertips below the nails, both before and after hand hygiene. Therefore, many healthcare institutions do not permit healthcare workers to wear artificial nails. According to the CDC, artificial fingertips or extenders should not be worn by healthcare workers who have direct contact with patients at high risk, such as those in the intensive care unit and the operating room. Additionally, tips of natural nails should be kept less than 1/4 inch, 1/8 inch for the Hack Rad 102 course and beyond. Most facilities also have rulings regarding nail polish, and it must be applied within the last 4 days and must not be chipped. Although this text, you will find reminders to perform hand hygiene. Hand hygiene refers to decontamination of the hand using soap and water, and antiseptic hand wash, or alcohol-based hand rub. Box 9-1 on page 156 and 157 lists the CDC recommendation for the use of alcohol-based hand rubs in the clinical setting. Housekeeping. Good housekeeping in the workplace reduces the incidence of airborne infection and the transfer of pathogens by formites. A clean, dry environment discourages the growth of all microorganisms. Much of the cleaning in the radiology department may be done at night by the housekeeping staff, but the radiographer is responsible for inspecting the work area regularly and maintaining high standards of medical asepsis. Several general principles apply whenever cleaning is required. Always clean from the least contaminated area toward the most contaminated area and from top to down. Avoid raising dust. Do not contaminate yourself or clean areas. Clean all equipment that comes into contact with the patient after each use. Use a cloth moistened with disinfectants such as a sandy cloth or Clorox wipes. The CDC recommends sodium hypochlorite, bleach, or Clorox as an inexpensive, effective disinfectant for preventing the spread of HIV. Hospitals have detailed written procedures concerning preferred cleaning agents at the extent of responsibility for disinfecting rooms. See Appendix F. Consult the infection control procedure in your clinical area. Handling and disposing of contaminated items. Handling linens. Objects or linens soiled by bodily secretions or excretions are considered contaminated and may serve as fomites even when no stains are apparent. Any linen used by patients should be handled as little as possible to prevent airborne contamination. Fold the edges of linen into the middle without shaking or flopping, and immediately place loosely balled linen in the hamper. Never use any linen for more than one patient. Most institutions today handle all linen the same way. Regardless of the degree of contamination, the linen is placed into a plastic bag. The laundry handlers follow established precautions to prevent infection transmission. Many hospitals provide laundry bags that dissolve into hot water, reducing the number of times linens must be handled by laundry personnel. Disposing of contaminated waste. A modern hospital may use many disposable items, from simple objects such as paper cups and tissues to more complex items such as catheterization sets. Disposable items are designed to only be used once and then discarded. The only exception to this rule involves the immediate reuse of an unsterile item, for example, emesis basin, by the same patient. Each hospital has a protocol for discarding disposable items. Some separate glass, plastic, and paper into covered containers, while others place everything following together. Follow the procedure for your institution.
Cleaning agents in the atrium at the extent of responsibility for this affecting.
Each hospital has a protocol for discarding contaminated items. Some separate glass, plastic, and paper into covered containers. When others place everything together, follow the procedure of your institution. Regulations demand that objects contaminated with enough blood or bodily fluid to cause dripping when the material is squeezed must be discarded into a suitable container and marked with the biohazard figure shown on 9-3 on page 158. Small amounts of dried blood or bodily fluid do not require this precaution. Good judgment is needed to avoid unnecessary usage of biohazard bins, which are expensive to provide and dispose of. Used needles and syringes are placed in a special container called a Sharps container that is designed to receive a syringe without recapping it. See figure 9-4 on page 158. OSHA's requirement for safer medical devices reduced the high number of needle sticks that previously occurred when workers had greater contact with unprotected sharps. A broad array of these safer medical devices are available. Some provide a sheath that slides forward to shield the contaminated needle. Others have a retractable needle that healthcare workers can draw back into the syringe after removing it from the veins. It is important to use these safety features to prevent accidental needle sticks. A needleless system provides the greatest protection from needle sticks and should be used to introduce medications and contrast media after initial venous access is established. See Chapter 14. Before sending specimens to the laboratory, place them in a clean container with a secured cap and slide them into a plastic bag labeled a biohazard. See figure 9-5 on page 159. Always wear gloves when assisting patients with bedpans or urinals. Be sure to empty these immediately unless a specimen is needed. See Chapter 10. Rinse them well over the hopper or toilet and discard them or put them into a proper place to be sterilized unless they are to be reused immediately by the same patient. Isolation techniques. Diagnosis or suspicion of communicable diseases is a reason for placing a patient in isolation before the development of UP. When it's recognized that all patients are potentially infectious, UP was late and later BSP was established. See page 169. Hospitals began using these new procedures in combination with their isolation policies, which consisted of 1 to 2 systems, a category-specific system with 7 different isolation or disease-specific systems, category-specific with 7 different types of isolation, or a disease-specific system. The CDC later added isolation procedures to BSP when forming the guidelines for standard precautions. The current guidelines replace both the older systems. Part of the CDC document guidelines for isolation precautions preventing transmission of infectious agents in healthcare settings is reprinted in Appendix G. Transmission-based precautions. The CDC now recommends isolating patients using transmission-based precautions as part of standard precautions instead of the category and disease-specific precautions. These isolation guidelines are designed to reduce the risk of airborne droplet and contamination contact transmission. They may be used separately or in combination with the disease with multiple routes of transmission and must be used with the standard precautions. Refer to Figure 9-6 on page 160 for examples of the precaution cards used in this system. Airborne precautions. Airborne precautions are designed to reduce the risk of transmission dust particles containing an infectious organism or bloodborne droplet nuclei 5 micrometers or smaller. To a susceptible person, airborne precautions are used to prevent diseases such as TB and measles or rubella. After healthcare workers and visitors enter a room of an infectious person must wear particulate respirators approved by the National Institute of Occupational Safety and Health, NIOSH. These masks must be capable of filtering particles 1 micron in size, have 95% efficiency, and should be test fitted to ensure safety. The most commonly seen particle respirator in the hospital is the orange flat N95 duckbill mask. See Figure 9-7 on page 161. This is an improvement of the mask that is powered. An improvement on these masks is the powered air purifier respirator, or PAPR, shown in Figure 9-8 on page 9-8 on page 162. These respirators are motorized systems that use a filter to clean the air before it is delivered to the breathing zone of the user. The system typically includes a blower, battery, headpiece, and a breathing tube. Some PAPR systems provide a higher level respiratory protection than non-powered air filtering respirators. A constant flow of air helps provide a feeling of coolness and greater comfort for the wearer. Loose-fitting headgear options provide respiratory protection without the need for a tight face seal or fitting testing. The battery-powered blower pulls the air through the filter, resulting in no additional breathing resistance to the wearer. Patients under airborne protection are placed in rooms with negative airflow and special circulation with more than 6 air changes per hour to the door and through the high-efficiency particle air filters. The doors of these rooms must always remain closed. Droplet precautions. Droplet precautions are designed to reduce the contact of large particle droplets greater than 5 micrometers or smaller in conjunction with the conjunctiva with the mucous membrane of the nose and mouth of the susceptible person. Droplet precautions is used to prevent the transmission of diseases such as diphtheria, pneumonia, and influenza. Healthcare workers and visitors coming in close contact with these patients must wear surgical masks, but no special air circulation is required in these rooms. If contact with the secretions is likely, gowns and gloves are required as well. Contact precautions. Contact precautions are designed to reduce the risk of transmitting pathogens by direct contact with the skin and mucous membrane, or indirect contact with a contaminated object. Contact precautions are used to prevent transmission of diseases such as multi-drug resistant wound infections caused by MRSA and VRE, the strain of E. coli 0157H7 and O104H4 that can cause renal problems and various skin infections such as impetigo. Healthcare workers who come in close contact with infected patients must wear gloves and gowns. Shared equipment should be decontaminated with disinfectant wipes. Contact previous precautions enteric, Clostridium difficile, norovirus, rotavirus, and endovirus are types of diarrheal illnesses that require disinfection procedures that differ from the regular contact precautions. Similarly, healthcare workers who come in close contact with infected patients must wear gloves and a gown. Alcohol-based sanitizer and disinfectants do not kill these pathogens, so shared equipment needs to be cleaned with Clorox bleach wipes, and healthcare workers are to wash their hands with soap and water. Combination airborne and contact precautions. Combination airborne and contact precautions are designed to reduce the risk of transmission pathogens by both airborne droplet nuclei and direct skin-to-skin contact. These precautions are used to prevent transmission to the virus that causes SARS and the visceral or virus that causes chickenpox and disseminated herpes zosters. Healthcare workers who have not had chickenpox should avoid contact with infected patients. Previously infected personnel need not wear masks. Radiography and isolation patients. Radiography of the isolation patient requires two people, preferably two radiographers. The dirty member of the team positions the patient, and the clean member handles the equipment. Although both radiographers must follow all designated isolation precautions, the clean member has no direct contact with the patient. The bed or the items of the patient may be touched. This radiographer is the only one who handles the X-ray machine and is uncovered image receptor IRs. This team method minimizes the contamination of X-ray equipment, which is difficult to disinfect completely. Before you and your teammate enter the isolation room, prepare the necessary IR by placing each one of a smooth-fitting plastic bag or pillowcase and donning your lead apron. Remove your jewelry and watch and place them in your pocket or pin them on your uniform when they are in your pocket or pin them on your uniform. At the door, you will find the necessary supplies for the required precautionary measures. For example, disposable gloves, gowns, and masks. These are posted isolation guidelines for the designated types of isolation. Don protective clothing. See procedure 9-2 on page 163. And enclose the IRs in a protective cover. See figure 9-9 on page 165. If the room was designed well for isolation, this procedure may take place in a vestibule adjoining the patient area. Now you are ready to approach the bedside. Greet the patient, make introduction, and explain the procedure. Patients placed in isolation often tend to feel rejected and untouchable. You can help alleviate these feelings by expressing a friendly interest in the patient and by avoiding any display of fear or revulsion as you perform your duties. The dirty team member of the team places the IR appropriately, making sure that the exposure side is toward the X-ray tube. See figure 9-10 on page 165. The clean teammate positions the machine, sets the controls, and makes the exposure. As each team exposure is completed, the IR is retrieved and a protective cover partially removed. It is then offered to the clean teammate with the edge exposed. See figure 9-11 on page 165. The contaminated cover is placed in the proper container and the IR is stored in the machine compartment. When the examination is complete, make certain that your patient is comfortable and secure before removing your isolation attire. The correct method of removing your contaminated isolation attire is illustrated in procedure 9-3 found on page 166 and 167. Try to remove the gown and gloves as one unit so that you never have contact with the contaminated outer surface. First, remove your gown and gloves by firmly pulling the gown away from the front of your body to detach the neck, string, and waist belt. Take care to hold it away from you as you fold the contaminated sides together and place it into the trash. Then untie the mask strings and remove the mask without touching the contaminated face portion. Hold it by the strings or rubber bands and place it in the container provided. Next, repeat the hand hygiene. Clean the mobile x-ray unit thoroughly before taking it back to the radiology department. See figure 9-12 on page 166. My apologies. It's actually 168, not 165. If additional images might be needed, you have to leave the unit in a safe location just outside the isolation area and postpone cleaning until the images have been processed and evaluated. When no further exposures are needed, push the unit back to into the corridor for cleaning. Isolation patients in the radiology department. If it is necessary to transport an infectious patient to the radiology department, the first step is to identify the isolation category involved and prepare the examination accordingly. Cover the stretcher or wheelchair in a sheet when no other sheet or cotton blanket. Then cover the stretcher or wheelchair in a sheet, then another sheet or cotton blanket. Depending on the isolation category involved, you may need to protect yourself and your uniform by wearing a gown, mask, and gloves. A patient with respiratory disease should wear a mask while being transported. See figure 9-13 on page 168. Transfer the patient into the wheelchair or stretcher, folding the inner cover around the patient and then the outer cover, tucking them both securely. Once the patient is ready to travel, you may be required to remove all PPE until you have arrived at your destination. This prevents the contamination of your surface you are touching while transporting the patient. When you arrive in the radiology department, take the patient directly into the x-ray room if possible. Protect the table with a sheet. Work with a partner so that one radiographer handles the patient and the other handles all the equipment and controls. As previously described, position the patient and make your exposure as efficiently as possible. Return the patient to the wheelchair or stretcher, wrapping them in the blanket. Place the sheet on the table and any other contaminated linen in the linen bag. Place tissues, caps, and other disposable contaminated material into the proper container. Disposable container materials that are not soaked in blood or body fluid can be placed in a regular trash. Anything wet or contaminated with blood or body fluid must be placed in a red bag or a special container marked with a biohazard symbol. After returning to the patient to a bed, remove your gown and gloves and perform hand hygiene and previously described. Clean the wheelchair or stretcher, repeat hand hygiene, and return to the radiology department. During this period, your partner should finish cleaning any other equipment used, including the table, and should complete the task of hand hygiene. Protective precautions. Protective precautions are designed to prevent the spread of infections to compromised patients. A compromised patient has a very limited immunity and requires special precautions to avoid exposure to potential infection. These patients may have undergone organ transplant and may be taking immunosuppressant medications. Burn patients and neonates at a risk may also require these precautions. Protective precautions are sometimes used for patients receiving chemotherapy, which reduces their resistance. The precautions were once referred to as reverse isolation or protective isolation. Federal isolation guidelines published in 1983 eliminated the category of protective isolation, largely because the purpose and procedures are the opposite of those of the isolation categories. The basic principles are unchanged, and you may find that these terms are still used in clinic settings. The correct terminology should be protective precautions or neutropenic precautions. Precautions for the compromised patient require that the equipment be cleaned before entering the room. Hand hygiene is required before touching the patient, the bed, or article handled by the patient. Masks, caps, gowns, and gloves may provide additional protection for the patient at risk. In extreme cases, sterile gloves and gowns may be worn in the same manner used in the surgical procedure, see Chapter 18, or a modification of surgical asepsis may be indicated. The modified technique results in a very high degree of asepsis without requiring the rigorous protocol of sterile technique. Outside precautions are posted outside the patient's room. Under the system of protective precautions, the radiographer who positions the patient is the clean member of the team. Wearing the proper protection clothes, this radiographer avoids the contact with uncovered IRs, the X-ray machine, and other potentially contaminated articles. To cover the IR properly, this radiographer folds back the edges of the sterile cassette cover and holds it open, with the second radiographer placing the IR inside. Care must be taken to not contaminate the outside of the cover. See figure 9-14 on page 168. The clean radiographer touches only the patient, the bed, the covered IR, and the clean or sterile items, whereas the dirty radiographer touches only the equipment. These roles are the exact opposite of those in the isolation technique. This concludes Chapter 9 of the PCR.